In this video, we are going to talk about the determinants of glomerular filtration, about autoregulation of the glomerular filtration rate, and about measurement of the glomerular filtration rate. The first thing that we will talk about is the determinants of glomerular filtration. Glomerular filtration is governed by the same forces, the Starling forces, that govern fluid movement across all capillary beds. The equation for glomerular filtration rate is given here. And let me explain the variables one by one. Kf is the product of the glomerular capillary surface area and the intrinsic permeability of the glomerular capillaries. Pgc is the hydraulic pressure within the glomerular capillaries, and this hydraulic pressure promotes glomerular filtration. Pbs is the hydraulic pressure within Bowman space, and that opposes glomerular filtration. Πgc is the oncotic pressure within the glomerular capillaries, and that opposes filtration. The oncotic pressure in Bowman space is essentially zero, since proteins are not filtered across the glomerular capillaries, and so this term can be effectively omitted from the equation. In normal humans, the glomerular filtration rate is about 100 to 120 milliliters per minute, or about 180 liters per day. If GFR is less than normal, the patient is said to have renal failure or renal insufficiency. Let's talk a minute about how perturbations in some of the variables in this equation can lead to renal failure. Patients with intrinsic kidney disease may have obliteration of the glomerular capillaries. Therefore, the glomerular capillary surface area is very low. Kf will be low, GFR will be low, the patient will be said to have renal failure. A patient in shock will have very low arterial pressure and will have a very low Pgc, low hydraulic pressure within the glomerular capillaries. Now, humans have ability to counteract low blood pressure to some extent. However, if blood pressure is low enough, those mechanisms will be overcome, and a very low Pgc will ensue and will result in renal failure. A very high hydraulic pressure in Bowman space will lead to a diminished GFR and renal failure. A couple of clinical circumstances come to mind. A common cause of acute renal failure in hospitalized patients is something called acute tubular necrosis, or ATN. ATN can be caused by renal toxins. It can also be caused by ischemic damage to the kidneys. In both circumstances, sloughed cells and cellular debris can obstruct the tubular lumens and result in an elevated hydraulic pressure within Bowman space. Again, referring back to the GFR equation, that will lead to a low GFR or renal failure. Another common clinical circumstance is the presence of a ureteral stone, a kidney stone. A stone lodged in the ureter will lead to an increase in hydraulic pressure proximal to the stone. So pressure in Bowman space can be elevated. That will oppose GFR and again lead to renal failure. Okay, next we are going to talk about autoregulation of the glomerular filtration rate. By autoregulation, I mean maintenance of a constant GFR over a wide range of mean arterial pressures. You see in this graph that between a mean arterial pressure of about 80 millimeters of mercury and a mean arterial pressure of about 200 millimeters of mercury, the glomerular filtration rate remains constant. There is a limit to autoregulation of the glomerular filtration rate, and it seems that the glomerular filtration rate falls off in humans below a mean arterial pressure of about 80 millimeters of mercury. Autoregulation of GFR is important. We participate in many activities that alter blood pressure in our day-to-day lives, and indeed, as physicians, we prescribe many interventions that alter the blood pressure of patients. Changes in GFR affect water and solute excretion. If GFR were to increase or decrease in proportion to increases or decreases in blood pressure, water and solute balance would be similarly effective and could put the patient in danger. So by uncoupling renal function, GFR, from arterial pressure, water and solute excretion will remain constant in spite of changes in arterial pressure that occur during daily living and as a result of diagnostic or therapeutic interventions. To illustrate autoregulation of GFR, let's look at what happens at the level of the individual nephron. And let's see what happens when blood pressure rises on the flat portion of the autoregulatory curve. An increase in blood pressure will lead to an increase in pressure within the afferent arteriole. This in turn leads to increased hydraulic pressure within the glomeruli, in other words, an increase in PGC, and this leads to an increase in glomerular filtration rate. However, phenomena ensue which reduce the PGC and the GFR to their previous levels. The increase in arterial blood pressure leads to stretching of the afferent arteriole and increased afferent arteriolar wall tension. This leads to reflex vasoconstriction of the afferent arteriole. Hydraulic pressure will drop distal to any constriction, and so PGC and therefore GFR will return to previous levels. This is known as the myogenic mechanism of autoregulation of GFR. Tubuloglomerular feedback is another mechanism of autoregulation. Tubuloglomerular feedback is discussed in the handout and in another video. Now let's look at what happens when there is a reduction in mean arterial pressure. When there is a reduction of mean arterial pressure, say from 150 millimeters of mercury to 80 millimeters of mercury, if there were no compensatory mechanisms, the hydraulic pressure within the glomerular capillaries, PGC, would fall, and therefore GFR would fall. However, there is a compensatory mechanism. As the mean arterial pressure falls from about 150 millimeters of mercury to 80 millimeters of mercury, there is dilatation of the afferent arteriole. This leads to increased hydraulic pressure within the glomerular capillaries, that is, increased PGC, and that leads to increased GFR. So GFR is returned to its baseline level. With a further reduction of mean arterial pressure below about 80 millimeters of mercury, another mechanism assumes greater prominence. Afferent arteriolar vasodilatation persists, but now there is efferent arteriolar vasoconstriction. This will augment hydraulic pressure proximal to the constriction. Again, this enhances hydraulic pressure within the glomerular capillary and helps to return GFR to its baseline value. Efferent arteriolar vasoconstriction is largely mediated by angiotensin II. Okay, now we are going to talk about the measurement of GFR. In normal humans, GFR is roughly 120 mils per minute or 180 liters per day. and it's the sum of the filtration rates of roughly 1 to 2 million glomeruli. As clinicians, we are interested in GFR. It is a measure of kidney function. If a patient has GFR that is below normal, we say that he or she has renal insufficiency or renal failure. So how do we measure GFR? Consider a substance which is freely filtered by the glomeruli, but not secreted by the renal tubules or reabsorbed by the renal tubules. Inulin, not insulin, but inulin is one such substance. It's an exogenous substance that has to be infused into patients. Again, inulin is freely filtered by the glomeruli. It's not reabsorbed by the cells lining the renal tubules, and it's not secreted by the cells lining the renal tubules. Therefore, the amount that's filtered by the glomeruli is equal to the amount excreted in the urine. The amount of inulin filtered by the glomeruli will be the product of the concentration of inulin in plasma and the glomerular filtration rate. Again, that will be equal to the amount excreted in the urine, and the amount of inulin excreted in the urine is given by the product of the concentration of inulin in the urine times urine flow, or urine volume per unit time. One can solve this equation to calculate the glomerular filtration rate. As I said in the previous slide, inulin is an exogenous substance which must be infused into patients. It is therefore cumbersome to use. Clinicians don't use inulin to determine GFR except perhaps in research protocols when exact GFR measurements are needed. Instead of using insulin, we use creatinine, which is an endogenous substance that's easily measured in the blood and urine. Okay? Let's talk about how creatinine is handled by the nephron. Like inulin, creatinine is freely filtered by the glomeruli. Like inulin, creatinine is not reabsorbed by the cells lining the renal tubules. However, unlike inulin, creatinine is secreted to a small extent by the cells lining the renal tubules. Therefore, the amount that appears in the urine slightly exceeds the amount that's filtered by the glomeruli. That is because creatinine appears in the urine as a result of both filtration and tubular secretion. The amount of creatinine that's filtered by the glomeruli will be given by the product of the concentration of creatinine in the plasma and the glomerular filtration rate. The amount of creatinine that appears in the urine equals the product of the concentration of creatinine in the urine and the urine volume per unit time. Again, because creatinine appears in the urine both because of glomerular filtration and tubular secretion, the amount of creatinine that appears in the urine slightly exceeds that that's filtered by the glomeruli. Therefore, the UV over P term for creatinine will slightly overestimate the glomerular filtration rate. But for us clinicians, it's close enough. Now we'll talk about how we measure or at least estimate GFR in clinical medicine using creatinine. First, we have the patient submit a 24-hour urine collection. We measure the patient's plasma creatinine concentration, and we measure the concentration of creatinine in the urine sample, and of course we know the volume of unit per unit time. We can then estimate GFR by plugging the values in the UV over P equation. Now let's look at normal values for a normal human. The normal plasma creatinine concentration is about 1 milligram per deciliter, give or take a couple of tenths. In this example, the plasma creatinine concentration is 0.8 milligrams per deciliter. The concentration of creatinine in this patient's urine was 60 milligrams per deciliter, and the urine volume was 2,000 milliliters over 24 hours, or 2,000 milliliters over 1,440 minutes. If we plug these numbers into the UV over P equation, we calculate that the GFR, or at least we estimate that the GFR for this human is 104 milliliters per minute. Remember that because creatinine appears in the urine both as a result of glomerular filtration and tubular secretion, 104 milliliters per minute is probably a slight overestimation of the glomerular filtration rate. However, it is close enough for us clinicians to use. It is a good estimate of glomerular filtration rate.